So I'm Casey Mullen, and I'm going to be quickly running through the multi-segmental rotation and single leg stance breakout. So the multi-segment rotation is basically broken into three portions. It's going to be the spine, then the lower quadrant external rotation of the hip and tibia, and lower quadrant internal rotation of the hip and tibia. So first we're going to start with the seated trunk rotation. So with this, we're going to have the patient seated. We're going to have them put their right foot over their left foot. Whichever foot's on top or going over the opposite foot, that's the side they're going to turn to. We're going to have their arms straight up, and we're going to have them turn to the right side. And then we're going to do the opposite, so left over right, turn to the left side. So as the doctor, I'd be looking through the AC joint to see if they can get to that 50 degrees on each side to see their rotation in the spine generally. If they're able to do this with flying colors, we can go ahead and skip the spinal portion of this and go straight to the lower quadrant. However, if they're unable to get to that 50 degrees, we're going to go ahead and test the spine. So to do this, we're going to do exactly what we did with lower multi-segmental extension. We're going to test the T-spine with the lumbar lock, active and passively. So actively, lumbar lock position, testing T-spine. If I'm testing left, doctor's on my right. The patient will put their arms to the lower back, look to that side, and look up. We want to see roughly 50 degrees here. Then the doctor would do it passively, so doctor's on my right side, left hand behind the patient's back, and then the doctor would loop their arm around the patient's arm and basically bicep curl it up. They want to see, again, that 50 degrees. We would do that bilaterally, so a patient comes to my left side, doctor's on my right side, arm behind the back, look up, 50 degrees. Then the doctor would do that passively, so they'll be standing on my left side, loop their arm into my arm, and bicep curl me up, and they want to see 50 degrees again. So keep in mind, if they're unable to do this passive or actively, we're thinking, okay, maybe they have a thoracic spine mobility issue. If they can do it actively, can't do it actively, can't do it passively, maybe a stability. So now we're going to go ahead and do the prone on elbow test to test the lumbar spine. So same position, except you're kind of throwing the back legs out. And we're going to do the exact same thing. If we're testing the left side, the doctor's on the right, look to the left, look up. We want to see about 30 degrees this time. Then the doctor's going to do it passively. They're going to loop their arm around the patient's arm and do a bicep curl. Then we're going to do the right side. So the doctor looks to the right, looks up. We want to see 30 degrees. Doctor's still on my left. Look up, and they're going to bicep curl my arm up. And again, we want to see 30 degrees. So once we roll in or out the spine, we're going to go ahead and test the lower quadrant portion. So to start out with, we're going to test external rotation of the hip and the tibia. So with this, we're going to start out with the prone active external rotation of the hip. So with this, the patient's going to just be laying down. The doctor is going to take the patient's leg and bring it to the knee and take it to about 90 degrees. And this is active. So doctor takes it to 90 degrees, and then they're just going to stabilize the pelvis and let go. Okay, so now we're seeing how much the patient's leg or the hip can externally rotate. We want to see at least 40 degrees here. Once we do this, we're going to do the stabilized prone for external rotation of the hip. And now we're just seeing if it's an acetabular issue or mobility hip issue versus core stabilization. So with the stabilized portion, the patient's just going to grab both sides of the table to get that core activated. The doctor's going to still, again, bring the knee up to 90 degrees, and then they're going to let go and let that hip externally rotate, and we're going to see if they can get to that 40 degrees still. If we're still unsure what's going on here, we're going to compare the active external rotation prone to the passive. So now we're going to do a passive prone external rotation of the hip. So patients relax now. The doctor is going to bring their knee to 90 degrees, and then they're going to passively externally rotate that hip. All right. So once we do all of that, we're going to go ahead and still test the external rotation of the tibia. So when we test an external rotation of the tibia, we're going to have them in a seated position. We want their knees and legs lined up. We want to make sure that their knees aren't bobbing or doing too much abduction, adduction. We're just going to have the patient one foot at a time externally rotate. Okay, so can't really see my foot, but it's just externally rotating. And we're going to look on both sides for at least 20 degrees here. If we're unsure if they're quite making it to that 20 degrees and we're having a hard time eyeing it, we're going to go ahead and do it passively. So we'll have the patient supine. So to test external rotation of the tibia, the doctor will take their leg, bring it up to about 90 degrees. They're going to grab the bottom of the foot here, and they're just going to externally rotate the foot themselves to see if they can actually get to that full 20 degrees. Once we're done with that, we're going to go to lower quadrant internal rotation of the hip and tibia. So this is almost the exact same thing, except all the movements will be internally rotated. So first we're going to do the active prone hip internal rotation. So patient prone, the doctor is going to come, stabilize their pelvis, bring their knee to 90 degrees, and then they're going to drop it and see how much the leg can internally rotate, or the hip, excuse me. Alrighty, after that we're going to do the stabilized prone internal rotation of the hip. So again, the doctor or the patient's just going to grab both sides of the table. That way their core is nice and activated. Again, to make sure it's not a hip mobility acetabular issue versus a core stabilization. The doctor is going to bring their knee up to 90 degrees, and then again, just let it drop outwards into an internal rotation. I believe we want to see, at least 30 degrees. If we're still unsure, we're going to compare active internal rotation prone for the hip and compare it to a passive. So, patient relaxes, doctor's still stabilizing the pelvis. The doctor's going to bring up their knee to 90 degrees again, and then they're going to passively put it into internal rotation, so the hip internally rotating. We still want to see that, that 30 degrees here. So the biggest thing with that is if they're unable to do it passively or actively, get to that 30 degrees here, we're thinking, okay, that maybe they do have a true hip mobility issue. We still want to go on to test internal rotation of the tibia. So with this, we're going to get into a seated position. We're going to have the patient 1 foot at a time internally rotate. So bring their feet inward. So just internally rotate. We're looking for the knee moving, the knees or the legs abducting, and on both sides. And again, we want to see 20 degrees. If we're unsure, about eyeing it, we can go ahead and do the passive tibia internal rotation. The patient will be on their back. The doctor will come down to the end of the table, bring their knee to about 90 degrees, brace the foot, and just internally rotate that tibia. All right, so that's everything for the multi-segmental rotation. We're going to move into the single leg stance. So with this, I don't have the pad here, but basically we're going to be testing 2 different portions for the single leg stance. We're first going to test the vestibular and core region, and second we're going to go into the ankle. So vestibular and core, we're going to be using the CT SIB. So with this, we'd have a foam pad, which I don't have here, but the patient would stand on the foam pad with their feet apart, here, and the doctor would be, to the side of them, and the doctor's just going to ask the patient to look forward and keep their eyes open for 20 seconds. We're looking for any excessive swaying, any nausea, dizziness, anything like that. If they're able to complete the 20 seconds and they still feel comfortable, then we're going to ask the patient to close their eyes. So basically here we're just looking at static versus dynamic vestibular issues for the CT SIB. So 20 seconds with their eyes closed. If they're able to complete that 20 seconds with their eyes closed, have them reopen their eyes again. Keep in mind 50% more swaying is allowed with their eyes closed. If the patient falls and experiences any of those sensations during this, go ahead and stop the vestibular portion, move on to ankle, because there's no need to really torture the patient anymore, knowing that they have a vestibular involvement. However, if they do pass this portion of flying colors, we're going to move into a dynamic portion where we're going to test basically the canals. We're going to test the 3 canals in the ear, all the different planes, to see how that fluid moves and how they can respond to the vestibular system that way. So with this, they're still on the foam pads. Their feet are still going to be about pelvis length apart. First, going to have the eyes open. And we're just going to, about 70 beats per minute, the doctor will stand next to the patient just to keep them on track. Only about 2 to 3 repetitions through each movement. So first, we're going to have the patient look straight forward with their eyes open, and we're going to have them just look left and right as if they're saying no. And then look forward. If they're okay with that, then we're going to have them look up and down as if they're saying yes. And if they're fine with that, no nausea, no falling, we're going to have them laterally flex to each side. And again, about 70 beats per minute, look forward. If they're totally fine with that, we're going to move on to the eyes closed. So, eyes closed. Oh, excuse me, we're going to rotate forward. When they look forward, their eyes are still going to be closed here. Then we're going to have them nod, and then lateral flex. And then after each session or rep, we're gonna look forward. If they fall or they get nauseated, dizzy, anything like that, go ahead and stop it. No need to move on. They do have a vestibular component. Next, we're gonna move into the kneel position. So with this, we're gonna have the patient get on one knee on the foam pad. Their back foot is gonna be nice and plantar flexed. Their front foot's gonna be in line with their knee and their hip. They're gonna be in a nice kneeled stance. And then we're just gonna ask the patient to get up and give them about 2 seconds leeway to get, stabilized. However, if they're just, flopping back and forth, that's automatically a positive for this. Have them test both sides, plantar flex in the back foot, forward. So if they were, really wobbly, let's say they were positive on this right leg, we'd go into what's called a quadruple diagonal. So the patient would kind of relax that thoracic or that spine, get on all fours, and we're gonna test the better side first. So if my right side was the one that's having some issues, we're gonna test this left side by bringing up the leg and the arm simultaneously, opposites. And then we'll test the bad side, which I think I'm pretty positive on both sides. So once we're done with the vestibular core portion, we're gonna move into the ankle. So keep in mind that was kind of basically disregarding the ankle. It's plantar flexed. We're not incorporating that. We're not having it as a factor. So now we're gonna go ahead and tackle all 4 ranges of motion within the ankle: dorsiflexion, plantarflexion, inversion, and eversion. So with this, I'm actually gonna move. Sorry. Because I'm gonna need a wall for this portion. Okay, so to test dorsiflexion and plantar flexion, we're gonna do what's called an active tandem dorsiflexion. So first, I'm gonna go ahead and put the right foot against the wall. The left foot's gonna be right behind it in that tandem position. The patient's gonna make 2 fists against the wall. Keep in mind that if the elbows are way behind, that means they're too close to the wall. If they're way in front, they're probably too far away. We want the elbows, about 90 degrees to the sides of the rib cage. So for dorsiflexion, we're testing this left foot here. We're just gonna have the patient dorsiflex up. I don't know if you can see that. Dorsiflex their back foot up, and then move it around in the planes without their knee moving to see if they can clear that dorsiflexion. To test for plantar flexion, we're just gonna have them bring their front foot up and plantar flex. We wanna see about 40 degrees for that plantar flexion. We will do this on both sides, so switch feet, make sure the elbows are in place. So again, we're gonna do the active tandem. So dorsiflexion, move in all the ranges of motion, left to right, then plantar flex up 40 degrees. If they clear that, we're gonna move on to eversion and inversion. So we're gonna do an active seated inversion and eversion. We'll have the patient sit down. We want their ankles, knees, and hips right aligned. If there's armrests, have them just kind of lay it on each side so that way they're not using their arms. Now we're just gonna have them take their feet and move them eversion, inversion. So just move them around, which I know you can't see very well. So as a doctor, I'd be watching if they're moving their knees a lot, using the hips, moving their body. If we do see a lot of knee involvement, we can go ahead and test this passively as well. So with that, we would just have the patient lay down supine. The doctor would go to the end of the table, kind of pistol grip under the foot, and just move the patient's foot into eversion and inversion for them. Another thing, if they were to fail the dorsiflexion and plantar flexion active tandem test, we could go ahead and test that passively as well, which the patient would be on the table prone. We would just start them at 90 degrees dorsiflexion or ankle flexion, and then dorsiflex them to 20 degrees to see if they can get that. And same with plantar flexion, start them at 90 degrees and just try to plantar flex them down.